Hello students, my name is Moon and this is Disparities in Healthcare. Disparity, or the differences, or the diversity of people in the U.S. is one of these nation's strengths. We are not a monolithic culture, and I know monocultures have its benefits, especially in short-term response to stresses and challenges, but in a long-term sustainable way for a country to be strong and remain strong, really the best way is when different people contribute different strengths, different talents, and that is why diversity is so important. Up until recently, the majority of America, ever since the founding of it, 200 years ago, over 200 years ago, was white non-Hispanic. But that percentage has been going down with increasing international immigration. So there's actually a projection that by 2050, which is not that far away, which is only like a quarter of a century from now on, it took 24 years to get from 2020 to now, and it's going to take only 26 years to get to 2050. By then, the majority of the US population will be not white. Now, each individual ethnic group will still be a minority. The white European descent Americans will still be the largest percentage, but it'll be below 49.9% by then. And that has serious, important changes, consequences to everything, every way we live our lives in 2050. For example, politics, right? One person, one vote. What happens if white European descent Americans are no longer more than 50% of the nation? Politicians will have to say different things 25 years from now than they are saying today. So who are the largest ethnic groups? Well, the largest ethnic group is white European descent. Trick question. The largest ethnic group is white European descent. The largest minority group is Hispanic. See how this works? So watch out, because I could say on a test question, which of the following is the largest minority group? And the answer is Hispanic. Which of the following is the largest ethnic group? And the answer is white, not Hispanic, European descent. And so Hispanic is the largest minority, followed by African Americans, and then Asians, and then Native Americans, and then everybody else. That has resulted in these minorities, however, don't have the same political power, and they don't have the same financial powers as non-Hispanic white Americans, and it reflects itself in disparity. So let's go back to the main title of this lecture, disparity. Diversity is the differences of inputs and contributions and people in a community. Disparity is an unequal sharing of resources, and the word the prefix dis means not is bad. Okay, it's a bad, unequal sharing. So it's an unequal sharing that's not fair. What is an unequal sharing that is fair? Well, how about competition? A fair competition in sports, right? There's one trophy, a bunch of teams are all competing for it, but only one team can finally get the trophy at the end. But as long as the competition is performed fairly, then all involved will say, yeah, that was, even the losers will say, yeah, that was fair, good game, congratulations to the winner. We'll do it next time though. Next year we'll be back and we will win it for sure. So everybody agrees that it's fair, that only one person can get the prize, the trophy, but they understand that it was the competition was fairly run. Well, that's not what's happening in healthcare, especially access to healthcare and affordability of healthcare. So disparity in healthcare is unequal accesses to resources to result where that there are different and unequal prevalences of disease, burden of disease, other detrimental health conditions, such as, I'm jumping around slides, hopefully you guys can keep up, such as, for example, low birth weight. So here, look at this. From 1999 to 2014, so up to 10 years ago, when this result was published, well, actually in 2019, among non-Hispanic whites, there was a 3.92% of newborns with low birth weight, but then non-Hispanic blacks, it was 3 times higher, from almost 4 to almost 10, more than 3 times higher. Among Asians, it was twice as high, and among Hispanics, it was a little bit higher, like almost double. Not really double, but it's still higher. Why? What's causing these higher rates of low birth weight among newborns compared to the majority of the U.S. population? Well, next slide. Here are some suspects, and this is classic example of a multifactorial risk factors. So you can't just point to one and say that's the cause, but it's each cause, each of these individual causes is contributing the risk factor, and the more an individual is suffering from each one of these, like check marks, then the higher the risk factor for adverse medical situations and conditions, and unequal access to health care, and an unequally high prevalence of diseases. If you look carefully, if you think carefully about each one of these, I think a lot of this can come down to financial. Because when you show up at a hospital, when you show up at a clinic, in the end, what really counts is not the color of your skin, but the color of your credit card. What really counts is not the title of your name, but the title of your health insurance. And the kind of health insurance you get depends on your financial situation. Where you live has a lot to do with how much, where you can afford to live. If there are mental health disorders, and then financial ability will determine how much access the patient will have to therapists, to psychologists, to advance the latest and greatest techniques. So money is at the root of many of these problems. Not all problems, but many of these problems. Disparity is not only about race, which is usually the most people's default, but can also be in all of these other categories here. So you can pause and inspect each one of these. Go to the CDC article where I got this from. But if you look at each one of these, then hopefully it makes sense right away that people in each one of these sub communities, smaller communities, subsections of communities, will be suffering disparities too. No matter which of these communities you are part of, here's an example, student loans. Being in a minority that is impacted by financial status, then your access to student loans is also changed. If you're coming from a rich family, a well-to-do family, then why would you need student loans? Some do. Some still end up going for student loans anyway, but their access to student loans is much easier. Their interest rates are much lower if there's a stronger financial backing behind underwriting that loan. This is not an article to a science article. This is just a YouTube channel. This is the YouTube channel, and of the videos I've seen so far about them, I'm pretty much in agreement. So I have kind of vetted this YouTube channel, and I support them. I recommend them for not just this article, but many other articles, many other topics they've talked about. Okay, when we talk about disparities, especially in society, there's this word, equity. Equality, I think you guys all know, if we want to share an orange and we split it exactly in half, we even get out the microgram scale and made sure that each half is weighed exactly the same. There, we just got an equal half. But that doesn't always mean it's fair, because what if the person who got exactly half of the orange needed more of it than I did? What if I just came from a full meal and I already had an entire apple, and I was thinking, I'm full, I don't think I can eat another bite, but that orange is looking really nice, so I would like to finish off with that orange. But then the other person who hasn't eaten all day, and this could be their only source of calories, their only source of energy, and so they had their eyes on that orange too, but there was only one orange left. And instead of fighting over it, some wise judge said, I will split it in two and each of you will get half. See how wise I am? I'm such a genius. But that's not actually an equitable exchange. So in the story that I just related, I think a more equitable sharing would be that we peel the orange and I get one wedge. I just wanted, to taste the orange, just to finish off a very large meal. So one wedge would have been good enough for me, and give the rest to that other guy, because he clearly needs it more than me. That would have been more equitable. And that's the difference, equitable versus equity. If you search the internet for the word equity, you're going to run into this picture here, and I got this from this website. So I haven't really examined this website in too much detail. I just needed to give somebody credit for my borrowing of this picture. So here is the example of equity versus equality. Same idea, different story. There are some who say that this is not a good example of equity, and this is not the ideal way to draw a picture of equity, but that's for like an upper level class. If the purpose of this slide is just to introduce this concept for those of you who have never heard it before. Like, one immediate objection is, are we helping these kids break the law? Something tells me that the only people allowed to watch this sports game are the ones who paid a ticket. And here are these kids trying to watch a sports game for free. So that's one cringe about this picture. I wish they had thought about some other way to demonstrate this. But anyway, here is that drawing. Okay, so health disparities. Some ethnic groups, as on the average, not per individual, but on the average, some ethnic groups minority groups especially, have higher rates of various diseases and medical conditions than others. Why? Well, one of the first things that people jump to, especially on internet comments, is lifestyle, behavioral choices. They're saying, well, if it's alcoholism, then don't drink so much. If you're fat, then stop eating. Go exercise. Stop. You're the one who put that cigarette in your mouth. Nobody forced you. So they're saying it's all about lifestyle. Other people are saying it's not just the individual, it's this culture. There's a culture of tobacco use. Their friends and their family and everybody in the community smokes. So this kid growing up in this community, how could they not smoke? Look around you when you were in high school. I hear vaping is really big in high school these days. So if you want to be cool, if you want to fit in, if you don't want to be rejected by your peers, there's like a massive pressure to vape. And vaping is not healthy. Vaping is a healthier alternative to smoking cigarettes. But if you were not smoking at all, if you were not using nicotine at all, but then your peers, your friends, the people you look up to are all vaping, then there's this intense social pressure to start, and that's bad. So there's culture and other activities resulting in beliefs that result in harmful behaviors and customs. But either way, either of these has their place. So they contribute a risk factor, but they are not the only risk factors. And to focus in on lifestyle, to focus in on behavioral choices, which these two represent, is kind of like blaming the victim. I'm not saying there's no free will involved. Of course there is. In the end, it is you who puts that, who reach for the extra serving of dessert. It is you who did reach for that cigarette. It is the culture and of your ethnicity, but it's not the only thing. To say it's the only thing is where the blaming the victim comes in, because there are many other things involved. Oops, let me go back to slide 5. So here it is showing that lifestyle, behavioral choices is just one thing. Custom, beliefs, ethnicity is just one thing, but there are many other things. Racism is not a fault of the ethnicity, it's a fault of the society that makes stereotypes and judges people on a shallow outer appearance or identity. So here, not in any particular order of severity or anything else, it's just the alphabetical order, are some other examples of diseases that are shown in disparity depending on, because of an unequal sharing of healthcare resources. Whenever disparity is mentioned or diversity is mentioned, then the first knee-jerk reaction is to immediately think of race and ethnicity. You can pause and read this for yourself if you are not sure what their definitions are. But then this entire semester has all been about evidence-based medicine. Evidence-based, not just what sounds right, but what has been proven to be right or wrong. And the problem here is that when you try to collect data on race and ethnicity, then it's hard to really zero in on exactly what is the truth, what's really happening. There are so many powerful special interests all trying to push their talking points, all trying to convince the general public to see things their way, that it's really hard to get accurate data through all of these steps, and especially through Congress and through politics. Some of the complaints about the collection of data, especially for race and ethnicity, is the unreliability of self-reported data. Some people take great offense when they are forced to choose from like a drop-down list of ethnicities and being asked, which one of these are you? And people would say, I'm not defined by a label. My ancestors or my identity is more complicated than what's on this drop-down list. Ethnicity and race are social constructs. It's not something that's actually, it definitely does not belong in like a biology lecture. It belongs in a sociology lecture and a politics lecture. So definitions keep changing and morphing over time. This kind of data, the attempts to accumulate this kind of data is through this department, Health and Human Services, and politics. Politics plays a massive part, and guess what? As a result of the latest election, then the way this department behaves will themselves experience a massive change in philosophy, in procedure, as the new administration comes in and starts telling this department, there's a new president in town, and now we're going to do things this way. So the way things are done are always subject to change too. So a couple of slides for each one of these, the four largest or the three largest ethnic groups. Hispanic region. So there's been, I am not, as I am not a member, I am not exactly sure what is the correct term, Hispanic versus Latinx. And each semester the students in class tell me that to be grammatically correct, Hispanic is any nation that speaks Spanish, and Latino or Latina is any nation that is in the Americas, speaks Spanish and is in the Americas. But Latino, Latina is gender context words, and so there is a Latinx, which is supposed to be gender neutral, and now among Latinos and Latinas, some like the Latinx label, some hate it. So I think that we're still waiting for society in general to come to a conclusion, come to a mutually agreed upon definition. Among all immigrants, not just Hispanic immigrants, but all immigrants, there is a phenomenon which is called acculturation. Acculturation, in a very oversimplified way, is, as far as healthcare is concerned, is that coming from their home country where they did not have access to higher income levels, economic levels, then they were forced to live a certain way, and as a result their health levels were of a certain way. And I don't mean worse or better, but in terms of, but let's say in the aspect of diabetes and high blood pressure, there was less diabetes, less high blood pressure, less heart disease in the old country where these immigrants came from, and not because their nation was that much better in healthcare. It's just that without the financial means, they did not have the opportunity to overeat, and they were forced to physically exert themselves to simply travel. But then they come to the United States, and especially their children, now can afford to overeat, now can afford to become obese, and now can afford to not exercise like they're supposed to, like we as human beings are supposed to. So obesity rates rise, and then the genetics, the precondition for genetics, the genetics for diabetes that was always there in the DNA is now given a chance to express themselves with this overabundance of carbohydrates. And so diabetes becomes a problem, and high blood pressure becomes a problem as they are growing up American. So that is acculturation, where health trends are different because immigrants eventually adopt the behavior and the diets of the host country, and then their disease rates change as a result. So I did say, so here's that word that I'm having trouble, my tongue is getting tied trying to pronounce, Latinx. I don't even know if I'm pronouncing it correctly. Diabetes. Diabetes is high among Hispanic Latinx at almost 20% as of the Mayo Clinic, compared to 8% of white Americans, white non-Hispanic Americans. Why? That is demographics, that's genetics. I don't think this article tried to explain why. This is so you can't get diabetes just from eating too much sugar. You must have the genetics for diabetes first. And then if you eat too much sugar, then the symptoms of diabetes will appear. There are people who don't have the genes for diabetes and they just keep eating and dessert and ice cream and cake and candies, nonstop. And they do get obese, they do get high blood pressure, they do get heart disease, but they don't get diabetes because they don't have the genes for it. While people with the genes for it but cannot afford all of those carbohydrates never show the signs for diabetes because they don't get a chance to. So how do Hispanic Americans have such high rates of diabetes? Why do they have higher percentages of their genetics? Higher percentage of them have genetics for diabetes. That is that is a question for sociologists. That's a question for archaeologists. This is a question for geneticists who trace these people groups all the way back to their origin, when they first intermingled between European Spaniards and Native Americans who traveled from Asia up and over Alaska and down into the continents. That's a question for people who study those things. Tuberculosis is another thing that is higher among the Hispanic population compared to non-Hispanic population. Tuberculosis is a problem all over the world. Less so in the United States because of our superior healthcare system when it comes to tuberculosis. There are many things in our healthcare system that are inferior in other diseases, but as far as TB is concerned, U.S. does a better job of keeping it under control. Anybody who is a healthcare worker is tested every year for TB. If somebody does come up with TB, then the antibiotics for it are more available, they're more affordable here, so it's under better control. But down south in the South American and Central American countries, it's not that. So that's not the case. TB drugs are less available, harder to get by. There's another thing too. In South America and Central America, they tried a TB vaccine. It didn't work. It was not as effective in preventing TB as it was hoped. So the U.S. never went with it. They decided, no, that we're not going with this vaccine, but South America did. But how does a vaccine work? Remember the infectious disease lecture? How do vaccines work? They introduce a protein, not the whole bacteria, but just the protein from its surface into the patient, and then the patient makes antibodies for it and remembers the experience, hoping that one of these days, if the real bacteria ever shows up, the antibodies are already pre-made and memory cells are already pre-made and ready to go. So that's the hope. But it was a failure as far as U.S. evaluators were concerned. But as a result, many Hispanics, people living in South America, they got the vaccine, they built the memory cells, they built the antibodies, and now if somebody gives them the TB test, which is inject a little bit of this protein. PPD stands for purified protein derivative. Purified what? Purified protein from the TB bacteria. And so it's not the bacteria, it's just one of the proteins on its surface cell membrane. They inject it under the skin and to see if the body reacts. And if the body reacts with redness and hardness after 3 days, then that's positive. But does this patient really have TB, or did they get the vaccine many, many years ago and they just happen to have the antibodies to react to it? And that's what's going on. If you know somebody, an elderly Hispanic individual who got the vaccine and they are in healthcare, they'll probably tell you the story of how every year they take the PPD test, they come up positive, and then at first they went to go get a chest x-ray to confirm if they have real TB or not. It turns out they don't, it's negative, and so for the rest of their life they have to carry around this letter from their doctor saying to whoever it is concerned, this patient does not have TB, they had the TB vaccine, and that's why they're coming up positive. There. But anyway, tuberculosis is prevalent in many countries outside the U.S., but one of them is in South America. So immigrants from South America and Central America too can show up with the real TB. Okay. African Americans, second largest minority in the U.S., and they have this unique history, U.S. history, that has been the basis of the stereotype and the racism off of it, and then the not only stereotype and racism among the general U.S. public, but even among healthcare providers, to the result that there is this one tragic story of how some doctors failed their duty to these individuals, and we'll talk about that. But the disease that is most well known among African Americans is sickle cell anemia. Sickle cell anemia is a blood disease. The details of it is far beyond the scope of this class, but the short of it is that it's a blood disease, and it, in situations of fatigue, low oxygen dehydration, it causes the sufferer to double over in pain, and then they cannot move, and they are completely debilitated for that moment, for that time. Sounds horrible. It's a genetic disease, and sounds horrible. Shouldn't a genetic disease this bad, shouldn't have been worked itself out of the population over generations? Why does it stick around? Well, the reason why is that the full disease, of course, is terrible, but the partial disease, the trait, the term is sickle cell trait, when you don't have the full genetics for it, but just the part of it, it actually provides defense against another worse terrible disease called malaria, which is prevalent in Africa, especially the tropical regions of Africa, coincidentally where many of the ancestor slaves were obtained from, that tropical middle band of Africa. So the recessive gene for sickle cell anemia, it was brought over in the slaver ships and persists in the U.S. population of African Americans. As long as it's in the trait form, it's not as bad, but through genetics, if two people with the trait have a child, and then one of those children have the full disease, and it's a terrible life. Every time they are tired, they are exhausted, and they are dehydrated, then they have a sickling crisis of extreme pain. All right, so, and I've responded to on the ambulance to patients with a sickling crisis What do you do for them? Well, if the problem is fatigue, then you give them rest. If they're low on oxygen, you give them oxygen out of an oxygen tank and a mask. If they're dehydrated, you give them fluids. And then, since they are in extreme pain, you give them pain relievers. And this pain reliever results in another problem. All the way back in chronic disease lecture, I talked about, or drugs, all the way back in the lecture about drugs, I talked about tolerance, where the more you use a drug, any drug, the more you use a drug, the larger of a dose you need again to have the same effect. So any patient who relies on pain relievers, pain medications, and keeps returning to them and reusing them, they build up a tolerance to the pain meds. So they need a larger and larger dose for the same effect. And at some point, they become physically dependent and even psychologically dependent on the pain medication. At each time they use it, they really, really need it. But the side effect that down the road, in the distant future, after having many sickling emergencies, they end up tolerant and then dependent on these pain meds. And so now what happens? They show up at the emergency room with a sickling crisis. They are in extreme pain, but after having lived a life with this, they know all about it. And the emergency room doctor says, it's okay, you're here now, we'll take good care of you. I'm going to prescribe to you some extra strength Tylenol. And this patient who's been living with it say, no doc, no, that's not going to work. That used to work like years ago, but it's no longer good enough for me. I need, and then they say the name of the drug that is even more powerful, a powerful pain reliever. And the doctor gives the patient a side eye, and then when he's outside of the exam room, he whispers to the nurse, this patient is a drug seeker. So they no longer believe the patient is having a real emergency. They think the patient is only in the emergency room to get more pain meds. So that's adding insult to injury. The patient has sickle cell disease, and now they are suffering the insult of racism, stereotype. They're being called a drug addict on top of all that. What happens then? Either the doctor does not believe them and gives them inadequate pain medication, or the doctor does believe them, but that just continues the patient further down this road of dependency. Okay, so I said that for future reference, let me move this slide front, because I said that there is this story of mistrust of authority figures. I should jump right into it. So the Tuskegee syphilis experiment is only one of the examples where the medical community at the time betrayed the trust of their patients. The website is here, tuskegee.edu. That explains the full story. So syphilis is a sexually transmitted disease. There are 3 stages, and in the late stage of syphilis, it even results in mental disorders and eventually death. Al Capone suffered from syphilis, if that sounds familiar to you. And anyway, it's sexually transmitted, so it's not specifically known for a certain ethnic group. But what happened was these researchers thought they wanted to do a study on syphilis. So they needed a bunch of guys who were suffering from syphilis. So they went out and found almost 400 African American men and said, we're doctors, we're very smart, you can trust us. We're doing this research study, you have a blood disease, we'd like to help you, do we have your permission? And they didn't fully explain the situation. They didn't even tell these men that they had a sexually transmitted disease. They didn't even tell them they had syphilis. They just told them you have a blood disease. So that's kind of like telling half-truths which is like halfway to lying. And so these 400 men said, "Oh, you sure? Yeah, I am feeling pretty bad, and I can't afford health care. So you're willing to give me health care and a comfortable bed and 3 meals a day? Sure, yeah, I'll take part in your research." Never knowing that it was a serious, eventually deadly disease. But then what happened? Were they treated? No, they were not treated, because the point of the research was not to treat people suffering from syphilis. The point was to watch what happens if syphilis is left not treated. That was the whole point of the research, to leave the disease alone, let it ravage through the body, and just see what happened. So right there, this was a massive ethical problem. This was a massive ethical problem. And then just the idea that you're going to watch patients slowly die from a disease just to see what happened, that's a massive ethical problem. When the story finally broke about this experiment, there was a public relations disaster, and these doctors were put on the defensive, and they had to argue for their lives, their professional lives. They tried to argue that what they did was for science, for the good of mankind, but no, the world opinion didn't accept any of that, and these men were left defenseless. Since then, laws were passed so that this kind of behavior is illegal. And to this day, in order to do any kind of research, any research at all, whether in college, whether in a hospital, whether it's about an actual disease or even non-disease research, if you want to do research in economics or engineering or chemistry or computer science, if you want to do any research, and if any kind of life form, not just humans, but any kind of life form is involved, then the researchers have to go through so many checks and overviews and moderations, so many different steps in order to prove that every step of their research project is ethically done. Not only for this experiment, but for other times when researchers failed their ethical duty to protect the public, to protect their patients. So then, it's illegal to do anything like this anymore. There are strict laws in place. All researchers are rigorously held to a higher standard. So is that it then? Is everything forgiven? Is everything over? And no. Because the memory remains. The memory remains. I'm really scrambling my slides here. This belongs here. The memory remains, and the stories are continued, are handed down through the African American community of what happened. And the problem is that once trust is lost, it'll never be regained. Maybe an individual will forgive you, but they'll never forget. And this is true for any time trust is lost. Any time anybody betrays trust in any context, in any human activity, once trust is lost, it's lost forever. It can be forgiven, but it'll never be forgotten. So as a result, the African American community always has this wonder about, what about this vaccine you're trying to push on my community? Is it really supposed to help me, or are you trying to use us as lab rats? And that was some of that resistance to the COVID vaccine. Asian Americans, the sum of it is that higher rates of diabetes, also higher rates of cancer and heart disease. Why? Asian Americans do share some genetic background with Hispanic Americans because both of their ancient ancestors came from Asia over Alaska and then made their way down the American continents. So maybe that has something to do with it, but I'm just talking out my head now. I have no anthropologic evidence to say that. It was just my first thought. But either way, there are higher rates of the genes for diabetes in the Asian community. But when they were living in Asia, their parents and grandparents and great-grandparents, they didn't have the economic ability to overeat carbohydrates and sweets. They were forced to exert themselves at work and also to commute to work. So they ate less and exercised more. So many of them never got the chance to express their genetics for diabetes. But then they came to the US and they got acculturated. They ate like an American, and so the rates of diabetes and high blood pressure went up. The things we're putting in our bodies here in the US also increase rates of cancer too. American Indians and Alaskan Natives have suffered from financial constraints. So many Native Americans are recognized by the US government as an independent nation. But the problem with being an independent nation smack in the middle of a bigger nation is that the economic opportunities are just not there compared to like another nation that has access to their own coastline, has control over large areas of natural resources. So without those advantages or without those resources, Native American tribes are suffering in poverty, and then without the money, then they don't have the access to healthcare resources. There is the Independent Health Services Department of the United States, and this is not my word. This is actually their title. So, that's what the U.S. government calls this department. But anyway, there are attempts to try to address this, but it leaves a lot to be desired. Okay. Now, what about new Americans, people coming into this country from these various reasons? Well, they are especially vulnerable to exploitation, especially if they are non-documented. Then they can be bullied and harassed into keeping quiet, allowing employers and landlords to take advantage of them. Here's another example of healthcare disparity. The first one I showed you was low birth weight. Here's another one, infant mortality. So the number of children who died before they reach 1 year old. Per 1,000 births among white Americans, it was 4.5 for every 1,000 births. Among African Americans, it was 10.4. So six more babies per 1,000, or over twice as much. Why? Because of these reasons. Each one of these is not the only reason, but each one contributes to a risk factor. In fact, this slide belongs in higher up. Let me leave it here for now. If you combine the financial limitations, access to resources, and then the distrust among African Americans against authority figures. Justifiable, I believe, because once trust is lost, it'll never be regained. It can only be forgiven, but that's forgiveness only comes with time and repetition, a demonstration that trust is worthy demonstrations of trust. Anyway, between the two of them, incidences of cancer is actually higher among African Americans too. They don't get pre-screenings. They don't get the preventive maintenance. The ones who want to cannot afford it. On the average. Of course, there are African Americans who are financially well off, financially successful too. But on average, as an ethnicity, among the ethnicities, there's lower financial resources. Without primary care, without preventative doctor's checks, then diseases are allowed to lurk under the radar, being undetected, not being treated early, not being prevented until the patient starts to feel something bad. And then they finally go to a doctor, but by the time they go to the doctor, the fact that it is now noticeable, symptoms are now noticeable, means the disease is already pretty far along. And now the fix for it, if there is one, is more expensive, more complicated, more painful, harder to come by, and so this starts a vicious cycle. Diabetes first requires the genetic predisposition first, and then once they have the genes for it, then comes the intake, the carbohydrate intake, and that is not balanced by being burnt off in exercise. So eating too much and exercising not enough after you have the genetics. I already talked about this basically in chronic diseases and in the previous slides on this lecture. I talked about HIV infection in the global emergencies lecture. And this is a direct consequence of the lack of financial resources to not only prevent people from getting HIV in the first place, but then once a person does become HIV positive, they have to stay on these antiretroviral medications regularly in order to avoid the symptoms of AIDS, acquired immune deficiency syndrome. So that also takes money, that takes an insurance plan. Those without insurance, these drugs become prohibitively expensive. How do you get HIV? Sharing blood, sharing body fluids, whether it is unprotected sex or sharing dirty needles, and such as in IV drug abuse, and also in other ways to exchange body fluids. So to prevent HIV transmission through unprotected sex, you gotta wear a condom. But what if the people don't know? What if the people in the community don't know about condoms? They never got sex ed, or they were not educated on how important it is to wear a condom. Condoms are not just about pregnancy. It's not only about convenience. It's a matter of life and death. If the community is not adequately warned about the importance of condoms, then it's not taken seriously. Access to access to clean needles. Not becoming an IV drug addict is of course the best, but if somebody is addicted to IV drug abuse, then the next best thing to prevent the spread of AIDS in the community is to Get them clean needles. How do you get an IV drug abuser to use clean needles? Well, give them one. They're not going to buy one. Access to clean needles are very expensive, especially to somebody who just spent, let me talk about this some more. So condoms to prevent unprotected sex and access to clean IV needles. And this is about example prevention. And let's be a little professional here. Okay, so how do you get an IV drug abuser to use a clean needle? They're spending their last penny on this drug addiction, so they're not going to have any money left to buy clean needles. Another problem is they're leaving dirty needles lying around in the streets, on the subway cars, on the buses, in the taxi. Well, they're not going to use taxi. On park benches, on the sand in the beach. So that's another problem, right? So how do we get the needles out of the environment and get clean needles into their hands? And one way to do that is a free needle exchange program. Each word here is very important. So the idea is we can get dirty needles out of the streets if we convince the user to bring their dirty needle in and exchange it for a clean one for free. It has to be free, because if you charge money, then they're not going to pay for it. So they will refuse to participate in the program if you charge money. They will, if you teach them, if you educate them how important it is to use a free needle so they don't get HIV, then they'll bring in their dirty needle and not leave it lying around. And of course it has to be anonymous. If you force them to register, if you force them to provide a driver's license, it's not going to happen either. Free condom distribution? Question mark. Each one of these programs, however, has a controversy, which is each one of them, somebody is going to complain, wait, we can't give these out for free. That's encouraging them to do it. If you give free condoms to young adults, to teenagers, then you're telling them it's okay to have premarital sex. If you give free needles to drug addicts, you're telling them it's okay to use IV drugs. And we shouldn't do that. And I would say that is a very important conversation to have in society. You are absolutely right that in a perfect society, this should not be happening. But we live in the real world. This conversation should be happening between ethicists and religious leaders and politicians and scientists. Everybody should be involved. Community leaders, and this conversation is very important and must be happening. But until we organize that kind of debate, AIDS is still spreading, HIV is still spreading in this population. So to prevent the spread of this and other blood-borne diseases, can't we at least do this while we try to figure out how to make society better overall? Let me save before I have a computer crash and lose everything. Among the minority groups, immunization rates are lower. Part of it is because it's costly. If people who are in a lower financial level then they have jobs that suck up too much of their time. Um, some people have to use mass transit to extreme. I mean, like taking 3 hours to commute one way to work, because I lived that. When I was a brand new EMT, in order to get to my first jobs as an EMT, I had to take buses and subways, and it ended up being 3 hours one way total. So 6 hours a day I was commuting just to get to the job. So how are these folks supposed to take time out of their busy lives? Some of them have 2 jobs. How are they supposed to take time out of their busy lives to go get a doctor's appointment, or to even get immunized? And then the availability and accessibility of health services absolutely makes a difference. If it's a clinic that's closer, that'll help a lot. If there's a clinic that's cheaper, that'll help a lot. Or if a clinic even exists at all for a tiny village somewhere out in far away in the middle of the United States, then if it doesn't exist, then this is not even possible. And then finally, the distrust of authority figures. Are they really doing this for my own health, or are they doing this because of some secret government conspiracy? So many factors contribute to disparities, as I said. Financial is the big one, but there are many others. The community's level of education on average makes them either more or less vulnerable to propaganda and to fake news. The more you know, the more protected you are against misinformation. So what are the solutions? Well, no simple solution exists because it's a complicated problem, but everybody agrees with that. It's funny how everybody agrees that the problem is complex, but then one by one they try to suggest simple solutions. The simple solution doesn't exist. It is going to be long term, it's going to be painful, but it's worth doing. One of the criteria for a possible solution is that it has to be culturally sensitive. We're talking about disparities, right? And disparities are a result of unfair distribution of resources to a diverse community. So cultural sensitivity is absolutely critical in order for any program to work. Instead of forcing people to do something, empower them to do it. Take away the obstacles, the speed bumps, open the doors of access so that they can do it for themselves. Letting people do things for themselves is the best way to make behavior change happen. You can't force them to do things, you can't yell at them, you can't insult them to do things. They'll just dig down and dig deep and be they will dig in their heels and be stubborn. Instead, you open the doors and let them decide for themselves if a health recommendation is worth following. How are they supposed to know whether a health recommendation is a good one or not? Health literacy, so education. Cultural competence is a word that's being used a lot in healthcare these days in the past several years as awareness of cultural sensitivity grows among healthcare organizations, and more hospitals even have like cultural competence officers who are in charge of going through the organization looking for signs of ethnicism, racism, other violations of human rights. So showing increasing cultural competence among the healthcare providers is one way to regain trust and understanding. So it was lost. How can they win it back? Empowerment is a word you probably have heard all the time, but what exactly does it mean, right? It means giving the individuals the ability to solve the problems themselves. 3 levels of empowerment: um, social, political, psychological. Um, so each one of these ways is how individuals take control over their own fate, and take so that they can implement their own solutions to how to regain access to healthcare resources. Last slide. Advocate and activist are words that you've probably heard all the time. Sometimes it seems like they mean the same thing. Not exactly. Nobody's going to complain if you use one word when you meant the other, but just for definition's sake, an advocate is somebody who is not in the community that is being helped, where an activist is somebody in the community. So if we take a previous example of, let's say, sickle cell anemia, an advocate is somebody who does not have sickle cell anemia but is helping to fight for the rights of people who do. An activist is somebody who does have sickle cell anemia and is trying to do something to help themselves and by extension help their fellow people in the community. There's a phrase, listen twice, speak once, because you have 2 ears and 1 mouth. If you are an advocate, especially if you're outside the community, the best first step is to listen. Don't tell people what you think. Wait until you have heard what they think before you use your expertise, whatever it's in, to try to help people.